Happy Friday, everyone, and welcome to Conversations on Care, our Facebook talk show, bringing together healthcare partners, our clients, and caregivers to help families better understand and cope with aging parents with chronic care needs. My name is Julie Collada, and I am the proud founder and CEO of Open Arms Solutions. And Open Arms is a home care agency serving the Chicagoland area and focusing on inspired home care solutions for seniors with multiple chronic conditions such as dementia, Parkinson's, and other movement disorders. It is truly our mission to help our families through this journey and to know that their loved one is living their very best life possible. As a reminder, if you find these dialogues helpful, please give us a like and a share so that it can reach more people who need this information. If you have a question on topics you would like to learn more about, please write them in the comments below. We'd love to hear from you. Well, with me today is our very own Michelle Rubio, our senior care advisor and social worker. And our topic is prevention, intervention, and discharge planning. Welcome, Michelle, to Facebook Live. Thanks for being here.
Of course. Thank you for having me. I'm excited.
We're happy to celebrate you during Social Work Month because social workers add so much to people's lives, and you have added so much to what we do at Open Arms. And we thought about, well, we of course wanted to have you on for Social Workers Month, and we talked and discussed, well, what's a great topic that would be really important for families to hear about, and really our whole audience, families, our caregivers, and our professional referral partners. So you came up with this idea to talk about prevention, intervention, and discharge planning. But before we get into that, tell us about what inspired you to be a social worker?
Yeah, so sounds kind of cheesy, but I've always kind of known, I've had the innate feeling of wanting to be in the helping profession. So I didn't necessarily know that it was going to be social work. So I actually started working in schools, and I actually have my associates in early childhood. And yeah, so I worked a lot in after school programs. I was a camp counselor, and I was really focused on schools and helping kids. And along that path, I was very thankful for all the opportunities and being in the classroom. But what inspired me truly is that so my family, my grandmother came here from the Philippines as a single mother. She had 6 kids, and my mother was the oldest out of 6 children. And they came here with nothing and, a different culture, learning the American culture, and being a single mother obviously had its challenges with 6 kids.
Oh my gosh.
And so, growing up with an immigrant family and, learning the culture and trying to understand all of the factors that shape a human being really led me to wanting to explore the complexities of a human being and what makes them a human, aside from biological and, temperament-wise, but environment, socioeconomic status, all of those things. And so after doing education, I felt that I was a little bit limited in regards to exploring how I can help an individual in different ways and use my creativity in different ways. And so when I was in undergrad, I spoke to a counselor, an advisor, and, telling them about my interests. And I just felt that I wasn't there yet. I wasn't sure what I wanted to do. I was in education. I didn't feel fully fulfilled. And so they told me about social work. And for a really long time, I just knew like psychologists, therapists. And so I thought about that too. But then when I learned what social workers do and really gaining the bigger picture and focusing on all of the factors that contribute to a person, that's really what led me to become a social worker.
Oh, that's great. I appreciate that story. I learned a lot about you that I didn't even know. So what different roles have you had in your career in once you selected social work?
Yeah, so in undergrad, so when I was, I think maybe 18 to like 22, I was working with kids at schools, like I said. And then I actually worked in child welfare. So I worked with kids who were in foster care, who were in residential settings, meaning they needed more one on one therapeutic services because of mental health problems and severe behaviors. Um, and then after that, with my master's, I went to um, Department of Children and Family Services, but in the administrative offices. So I explored more of macro level work and how policy can affect programming and all those barriers. And so I looked at advocacy, policy, all those things in a larger picture. And then once I graduated with my master's, I got my first job working with people in a community health organization, working with people with mental health problems and disabilities. But my main focus was to work with the mental health department. And so I ran a lot of groups with adolescents and young adults. And the goal was to try to teach groups and activities where they could become independent in the community as much as possible and not let their mental health problems or disabilities define them, and integrate them into the community to be a thriving person in society. So that's what I did. And then after that, that's when I started my journey in healthcare, specifically in skilled nursing. And I worked as a social worker, and I worked mostly with long-term care. But I also did a lot of discharge planning. And then I was eventually director. And then I also did a little bit of activities as well, where I got to work creatively for activities for cognitive stimulation, functional stimulation, and building therapeutic relationships with families and clients. And then now I'm at Open Arms. So quite a mouthful there.
It's been a great year. I mean, you've had an amazing amount of experience, and consistent with everything I've heard you say and I've known about you is your keen caring and empathy for people comes shining through. And so you found the right spot. This is my unbiased observation, but it's actually a very biased observation, because I think you truly make a difference. And I think my observation of people who do the work that you do, or social workers do, is you have to love people, and you have to, have the mindset that you really want to make their lives better and help them figure out often very complex situations. So you landed in the right spot from my perspective. So thank you for sharing that. So why do you think it's important for you to cover this topic of what is a role of a social worker from your perspective?
I think this topic is important, and it's kind of just in my day-to-day language, even personally, and obviously in healthcare. No matter what setting you are, at least from what I've seen in healthcare, whether you're at a skilled nursing or you're at an outpatient rehab or you're at an independent living or home care like I am, having this conversation with families and clients as early as possible is beneficial, because oftentimes I see families and clients in a crisis situation. And because that's the lack of guidance and the lack of education, or just not enough time to plan for themselves or a loved one. And so it's really rushed. And there are definitely ways to prevent and to intervene when there are those risk factors. So it's just a very common thing that I see with families and clients. And as a social worker, it's our job to help clients navigate the system and overcome barriers that they may be facing, whether it's providing counseling, having difficult conversations, advocating, educating, and providing resources.
Yeah, it's so important. And certainly, when I started the company 15 years ago, my personal experience was all of a sudden, as the adult children, part of an adult child of an independent woman who all of a sudden wasn't independent and couldn't care for herself. And I knew nothing about what to do for her. I just knew it was the most important thing in the world to do the right thing for her, but I didn't know what to do for her. Mm-hmm. And what I've learned 15 years later is, and you just explained, you said it very well. I mean, even today, we try to educate, and we love to educate, and we love to go out and try to help people think about these things so they're not the urgent, scary situation with very limited options. I think it drives a lot of us in what we do. Mm-hmm. That's really well said, is, being able to educate people in advance so there can be better decisions made for their loved ones. So as a social worker, how do you, well, I think it makes sense right now to dive into the topic of prevention, intervention, mm-hmm. and planning.
Yeah.
So for everyone, can you describe, let's talk about some examples of prevention. First, what's the difference between the two? What's the difference between prevention and intervention?
Yeah, so prevention is obviously preventing, right? So taking action to prevent ill health, illness, and accidents, and overall staying healthy both physically and mentally by eliminating or reducing risk factors. So I think also in addition to that is normalizing the aging process. And that goes along with conversations of, having difficult conversations. And then intervention is taking the deliberate steps to increase safety for someone at risk. So not that it's too late, but when they're at risk and you're noticing these symptoms or side effects or just overall that you're aging, what can you do to increase your safety?
So those are all critical things. And can you give an example, Michelle, of a kind of a tough, uncomfortable conversation that you might have urged a family to have with their loved one so that they could prevent that disaster, that fall, that hospital admission? Can you give an example of what those conversations might sound like? Because they can be very awkward.
Oh, yeah, absolutely. And, I'm just going to use personally, and I'm sorry if my grandmother is watching, but, just with my grandmother or anyone that you notice is, their gait, that means their ability to walk, right? So sometimes you see people shuffling their feet and a little bit unsteady. And I can just notice because obviously I have a background in it, but when they get up from the chair, right, are they struggling a little bit? Are they a little wobbly? And then pushing a little bit harder, even from standing from the floor to standing up. So those things that's prevention in regards to the way your house is set up. So your chairs, are they really low to the ground? Because the lower they are to the ground, the harder it's going to be to transfer up from that chair. Rugs, it's a fall risk. So are rugs in a good place? Do they need rugs? Is it flat on the ground? Is it flipping up? Because that is a risk for falling. And just having those difficult conversations, because in their home, that's been their home probably for a really long time. So suggesting, new bathroom setup or new furniture could be even really hard for someone because it's their home. That's their personal things. So even those little conversations can go a long way, but it is still difficult to have them because you notice a decline.
Yeah, absolutely. Can you just suggest and think about how you might first broach that? What do you say to your loved one that you're concerned about? You notice that they're unsteady on their feet when they're getting up. How would you broach that to have the best chance of success?
Yeah, I mean, I think it also depends on the rapport you have with a person. So
Sure.
a stranger will be difficult, but also a family member could be difficult too, because some people want an objective opinion from like an outside source or a professional. Um, but I think if, for example, my grandmother is having a hard time getting up from the couch, just saying that you see, hey, grandma, do you need help getting off from the couch? Can I help you? Because that at least is starting a conversation and putting it in her mind, like, oh, I do need a little bit help.
Yeah.
So without like projecting and being like, grandma, do not do that by yourself, right? So there's a difference there. Asking, hey, how are you doing? Can I help you with that? And even just asking those questions kind of get that moving, the thought moving in their head.
Great suggestion. And I know for me, I wasn't successful with my mother in the prevention category. A very independent person, and even when before she had her strokes, um, it really didn't have the cognition to answer and really make decisions. But even beforehand, it was just, I don't need help. I'm in, are you
Mhm.
trying to take things away from me? In a very, she was very guarded about it. And I think the approach I might have, I'm trying to, now that again, I've been working with seniors and families for all these years. One of the things that I've heard other people do that made that conversation easier. And I wish I would have gone back in time and had this with my mom to see if it would have worked. Nothing's a guarantee. But I might have said, Mom, you know what? I'm just noticing some things that I'm concerned about you and I love you. And so it makes me very concerned that you're living here by yourself.
Mhm.
Can
Yeah.
we can we start to talk about this? So it's really about not about her, it's about me and how I'm feeling, and that sometimes works because you know it's not, moms tend to want to help their kids, and
Mhm.
sometimes that approach can work. There's nothing that's 100%, I think, which
Mhm.
is we know, but we both of us here, all of us here, that's really hard, is that intervention, that prevention step, to help reduce the accidents that we know are going to happen. Um, so what are some examples of prevention that you've seen to help reduce those accidents from happening?
Yeah, so like I said, I think the home environment and the setup is very important. And I think, people don't often think about that because when you're buying a home, you know, you're younger. So you're not thinking like, I want this bathroom to have grab bars because it doesn't matter to you at that point. Um, but to really think about, is there grab bars in the bathroom? Because you're at a higher chance of falling in the bathroom, especially if there's a tub, because going over the tub versus a shower, a walk in shower, and
Right,
grabbing on to something while you're walking in.
right,
So, and grab bars by the toilet, or, do you have rails by the stairs? Where is the laundry located? Is it all one level? How many stairs you have? Stairs are very common in regards to, is your home a good fit for you anymore? And then there's other things, right? Like monitoring side effects of medication, exercise, meditation, deep breathing exercises, socialization, and then diet and nutrition. That's overall that benefits everybody's mental health and well-being.
yeah, those are really important, great examples. So what are some examples of interventions you mentioned? So the title of this talk is Prevention, Intervention, and Discharge Planning. So let's talk about different kinds of interventions and what that means.
Yeah, so the five major steps to interventions are the 5 A's. So that means ask, advise, assess, assist, and arrange. So I'm just going to give you an example of someone who's hospitalized and needs care afterwards, right? So Say, for example, the person fell or had a stroke, ortho surgery, cancer treatments, any chronic conditions. And there's a change of condition where you're becoming at risk. You typically would be admitted to the hospital if you're, in danger to yourself, or you're really at high risk. And then you would be transferred to an acute inpatient rehab in the hospital or outpatient treatment or a skilled nursing, depending on what the team or the hospital recommends for a successful transition. And then you plan to go back home or wherever home is, and then arrange things you may need to be safe and healthy. So it sounds lengthy, but when you do have an accident or something happens and you do go to the hospital, you need to arrange the necessary, whether it's specializations or the aftercare, to make sure that you can reach baseline. And if you can't reach baseline, what are you doing after?
Those are good. Those are great examples. So, and there's a couple of viewer questions, and I think they're right in line with where we are now in the program. So, what strategies do you use when a crisis occurs?
Okay, yeah, that's a really great question. So, it's been a while since I've done crisis intervention, but working in a residential home with severe behaviors, I did a lot of crisis intervention. So my first thought is reaching equilibrium. So if someone's in a crisis, they can't think. They are not thinking, it's fight or flight. So they're really not, when their body is reacting first, you want to address that first. So have them calm down, deep breathing, do things that make them feel calm, or will go, if they're at a 10, go to a level 6, right? They're not going to go to a 0 right away. So when the crisis does happen, is having them feel safe, comfortable, and supported is really important. And once you can see that they're calm and they can have an actual conversation with you, and you can ask them, how are you feeling? Tell me how you feel. That's when you can start to intervene and decide what to arrange, right? Especially if they're cognitively intact, you want to ask them what they want. You want to honor that. And of course, with support and guidance, to have that conversation when they're calm.
Great, thank you. That was a great question from the viewers. And there's another viewer question. Let's make sure we get to that. How do you navigate conflicting demands between clients, families, and healthcare professionals? Great question.
Yeah, that is a really great question. So when I was in skilled nursing, I oftentimes had care plan meetings. And you can really utilize this in any setting, home care, skilled nursing, outpatient, whatever it is. So what I did is that initial contact, going over the goals with everybody. So having that first care plan meeting is crucial because you're setting realistic expectations for families, healthcare professionals, and the clients. And then you're trying to understand what the goals are from every perspective. So again, setting that standard from the beginning so that if something does happen, if they don't reach their baseline, then at least they're prepared in their mind that, we are going to try our best to get you there. But, we have to do therapy with you and see where you are, and we'll check in. So then I always had another care plan like 2 weeks after, and we talked about the progress or the lack of progress. And then closer to when we saw maybe they reached a plateau or it was time that they transition out, that's when we had to have a conversation about what levels of care they might need, what do they need to discharge. And so I think having the constant communication with everybody is really important to navigate the conflicting demands.
Well said and well done. It's amazing when you involve people in the process, how you get more, cooperation and collaboration. Not always easy to accomplish, but
no,
right? You make it sound very easy, but it's not easy, but so important. So, All right, let's keep moving on here. So let's talk about, you talked about the 5 A's of intervention. What would be, when something happens with a loved one, what are the different levels of rehab? And how is the decision made about where that person should go after that event?
Yeah, so the different levels are acute inpatient rehab. So that is typically if someone's in the hospital, they have an inpatient rehab, which is very intense. You're looking at like 3 hours of therapy a day. And then, the doctor or the physician is checking in every single day and everyone's in constant communication. And it's just a higher level of care. And then subacute rehab is skilled nursing. So that's less of staff to patient ratio. So also the therapy is less. So you can be doing like an hour a day, 30 minutes, but it's less intense. And for other options too, if those aren't something that the team members at the hospital recommend, you can go home and do home health or do outpatient clinics or private gyms with licensed therapists. So it really just depends on what the therapists recommend and what the physician recommends, because they need the medical side to see that you're cleared medically, but then to also see that you're functionally and cognitively cleared as well.
Yeah. Great explanation. Thank you for that. I think I have over the years witnessed, and I'm sure Michelle, you have too. It's incredibly wonderful when you see someone, who's had a stroke, but they had great medical care. People got to them quickly, and there was a decision made to do very intensive therapy because the therapist felt that they really could regain a lot of the function they lost from the stroke. And it's amazing to watch the professional team, so dedicated to getting that person. You mentioned baseline. Can you describe what baseline is to everybody?
Yeah, baseline is where you were previously to hospitalization. So people often say, I want to return to baseline when I was at home.
Sure. Great. Thank you for that. And the last part of this session, and then we're running short on time. I knew this was going to go fast, Michelle, and there's so much great things to talk about on this topic. But the last topic is the part of this talk is discharge planning. So we talked a little bit about discharge planning, but what as a social worker do discharge planners think about the most? What are the most important factors to think about in discharge planning?
Yeah, so discharge planning is a lot. And I give all the credit to all the discharge planners because it's very fast paced. But the most important thing you think about is, are you setting them up to be safe at home, wherever home is? And are you having realistic conversations with the clients and the families of the level of care that they need? And then also providing all of the resources that can be out there for them, because you have to take into consideration payer sources. There are different levels of living. So there's independent living, there's assisted living, and then there's home and skilled nursing and long-term care. So there's really just a lot of things out there that people don't realize. And so knowing the client and what their goal is going to be best for a social worker to set them up for success to discharge.
Yeah. And, what I've come to learn over the years is, discharge planners, it's a, boy, what a challenging job, right? They want to do the right things, as you said. They're chartered with getting the resources necessary to make sure people transition and stay home, don't get rehospitalized. And sometimes and often, and we see this too, and I think it's important for families to know, with all the different insurances out there, I know discharge planners are under, negotiating isn't probably the right word, but they're getting information from the insurance company saying, Mrs.
Yep.
Smith only has a day left on insurance,
Oh yeah.
right?
That wasn't my worst nightmare.
I'm sure it was. And I
Yes,
think,
yeah.
it is. It's just that you always want to do the right thing for people, but then you've got this other factor that's a reality where, and as a discharge planner, they're being told, oh, the patient, no more insurance, they need to be discharged now. And and that's a very challenging thing to navigate.
Yes, it really is. And just at that short amount of time too, you could get that insurance cut, and then you have to try as much as possible, because you do care, to transition them back as safe as possible with resources that apply to them.
Absolutely. And Open Arms wants to be that great partner to the discharge planner, to be able to be one of those resources to help people transition home safely. And we all love it in the healthcare system when we have some time.
Yes.
When we have, when there's those care plan meetings that you described, everybody's involved. We know we have maybe a week to now start really planning that process, getting the right resources involved, including home care. We just can take care of people better when we have that planning. It's just the challenge of the discharge planner that I've seen, and you've helped me understand even more since you've been with Open Arms, is just the realities that discharge planner has to deal with, the payor sources. And, of course, that skilled nursing facility, like anywhere, has to get paid. They have to, in order to keep quality care up, they have to get the revenue from the different payor source. So that's definitely a reality, a tug and a pull of the healthcare system. As this topic, though, and as you're reminding us all of, if we can prevent these crises from happening, first of all, if we can intervene, if we need to help people make the right decisions, and then plan, that's the incredibly important role of a social worker. And my hat's off to that profession, because you help families navigate very, very complex healthcare systems, and with the goal of having people stay safe and be well. So, well, we're flat out of time, Michelle. Thank you so much for being a guest. I knew it would be fun and very informative to have you. So thank you so much. And thank you for everything you do for our clients at Open Arms. We're really grateful to have you part of the team.
And thank you for having me. It was fun.
Thanks, Michelle.